Yeah. Okay. Now it's working. Yes, so am I audible? Is the screen visible? Please do let me know so that we can start on time. Yeah, Pradit is there. So thank you. That means the screen is working. Thank you. Now it's working. Good evening all. Just mute all the mics. Okay. Ashim, thank you, Lucky Africa. Fine. So today we are going to start with some random topic because what I believe is that if we keep a longer class, the classes they tend to get boring. So today we'll keep a comparatively shorter class. We'll be doing some selected topics only. Hello, all Priyam ji. Oh my God, Priyam is also here today. Rivan, Riaz, hello buddy, Nishail, Arabrat, Siddharth ji, Lucky, Hashim. So good to be with you all. Fine. So today we'll be doing the topic of intestine. Small random selected topics of intestine. Fine. Now, okay. So I have delivered a separate PPT of the concise class. Fine. Now you see here. So the intestine that begins at the duodenum. Fine. And you know what marks the beginning of the duodenum is pre-pyloric vein of Mayo. So proximal to this vein, hello buddy, hello Dr. Chabi Panthi, I hope I'm pronouncing your name correctly. Hello Dr. Mayavi Gaming, Dr. Venkat, Dr. Bharat Kumar, Siddharth ji, so good to be with you. Fine. So pre-pyloric vein of Mayo. So anything proximal to this pre-pyloric vein of Mayo is stomach, and anything distal is duodenum. Fine. Now you see duodenum has got four parts. Fine. See, the first is called the superior duodenum. That is the first part. Now that is the only part which is intraperitoneal, and this is the most common site of peptic ulcer. We read yesterday. Fine. The second part is also called descending duodenum, and that is the part which has ampulla of Vater. In this part only the bile will flow. Fine. Inferior part. So inferior part will lie just inferior to the pancreas. That is the third part, which is horizontal. Fine. Good evening, Dr. Shubham. Good to be with you. Subhash, good evening, buddy. Fine. And then the fourth part. So here is suspensory muscle and the ligament of the duodenum. Fine. So this will open up and the content will enter into the jejunum. Fine. So here I told you pre-pyloric vein of Mayo. That will differentiate between the stomach and the duodenum. Fine. And here the suspensory ligament will differentiate between the duodenum and jejunum. Now ileum and large intestine will have ileocolic junction. How do you differentiate between the jejunum and ileum? So arbitrarily, the proximal 2/5, see, intestine is around 6 meters in length. So proximal 2/5 is called as the jejunum and distal 3/5 is called as the ileum. Hey Dr. Sunny, to be with you. Fine. Now the difference there. Fine. So wider diameter ileum is comparatively narrow. Fine. The plicae circularis, the folds. Fine. So they are more circular. Fine. They are comparatively less circular and they are thinner. Fine. Now what we have to see is this appearance, the vasa recta. Find these blood vessels, the vasa recta. They are longer and fewer in jejunum. Fine. While they are shorter and more numerous in the ileum. Fine. Now you see here, ileum also has got Pierce patches. There are no such lymphoid aggregates in the jejunum. Fine. So see over here, the lymphoid aggregates, they are called as Pierce patches. Good evening, Dr. Jawahar. Now, this is how we differentiate between the jejunum and the ileum. Jejunum and the ileum. Fine. Jejunum and the ileum. So we have to just differentiate based on the certain characteristic clinical feature. Now, yesterday, before we could finish the topic of stomach, we did discuss this topic. Fine. But let's do it again. There's no harm doing it again. Fine. So what is this topic? This topic is duodenal atresia. Duodenal atresia. Fine. So you see, most commonly it will affect the third part. Fine. So see, duodenum is like this. Duodenum, let's say, is like this. Then what happens is it canalizes. Fine, like this, canalizes. Fine. So this is normal canalization. So this would be abnormal canalization. Fine, you see, suppose this part, it has failed to canalize. Fine. So previously this is cord-like, then it becomes like a tubular structure. So the cross section, suppose it first appears like this. Fine. Then the cross section becomes like this. That means a lumen develops. So failure of development of the lumen is also called as failure of canalization. Now, there are so many D's over here. First, duodenal atresia, the condition. Fine. It is associated with Down syndrome. Fine. So let's draw a diagram to understand it. So let's say this is the normal duodenum. Fine. And here are entering the bile ducts. Fine. Here are entering the bile ducts. Sorry for the bad hand. Very poor drawing. Fine. Here are entering the bile ducts. Fine. So bile is freely flowing. This is one condition, and this is what happens when your patient has duodenal atresia. So third part is affected. What am I trying to say over here? That the bile will keep on flowing normally. Like this. Right. So bile will keep on flowing normally. But this bile cannot go out, so this bile will be vomited out. So characteristic clinical feature will be abdominal distension. You see here, I told you the first part, second part, third part, and the fourth part. Fine. Now there will be abdominal distension, and then there will be bilious vomiting. Hello, Dr. Shrana. There will be bilious vomiting. See over here. Right? Bilious vomiting. Right? Now, see here. Duodenal atresia. Told you closer of a 2. Fine. So, like this. See. Now, double bubble appearance. There is characteristic double bubble appearance. Fine. Double bubble appearance. This is all what you need to see. Here. Fine. Now, this is very, very rare. Right? Now, what is the treatment there? Fine. So treatment in this case is duodenostomy. Fine. Duodenostomy and duodenojejunostomy. So either of the two, that depends upon the choice of the surgeon. Fine. Now, for example, you see, that brings me to another question here. For example, we are slightly deviating away from the topic, whether to perform duodenostomy or duodenojejunostomy. Fine. Now, for example, there is one condition called potato tumor of the sternocleidomastoid. potato tumor of the sternocleidomastoid. That is what we see in the in the development of torticollis, like this torticollis. Fine. Now, what is the treatment there? Resection of the sternocleidomastoid muscle. Fine. I was attending the class of an illustrious teacher, very famous teacher. Fine. So what it did ask was that which part is to be removed, whether you are going to remove the sternal head or the clavicular head. Fine. So some of them said sternal head, some of them said no, it is a clavicular head. The answer is that it depends upon the wisdom of the surgeon. While he is doing it intraoperatively, he is the one who is going to choose. He is the one who is going to choose. Fine. So here also it is the wisdom of the surgeon. He is the one who is going to choose what surgery needs to be done. Fine. So we come to the next topic, that is the Dr. Jaka Ibrahim. Thank you. Welcome. Now, Hirschsprung disease. Hirschsprung disease. Now, you see what happens in the Hirschsprung disease. Fine. Now, this is what is seen here. Fine. No enteric nervous system. No enteric nervous system is there. Fine. No Auerbach, no Mischner plexus in this zone. No Auerbach, no Mischner plexus in the affected zone. In the affected zone. Just a second. No Auerbach or Mischner plexus in the affected zone. Fine. Hirschsprung disease. So there is absence of Mischner's plexus and Auerbach's plexus. Auerbach's plexus. Now, same thing happened in Atresia, but here what will happen? The affected segment will be contracted. Remember, in Atresia, the affected segment was dilated. Fine, because with the peristaltic activity, with the voluntary upper esophageal muscle, the food contents, they are thrown to the affected esophageal segment, which keeps on dilating. But here, the affected segment will be contracted. Fine. So this is associated with Down syndrome and Waardenburg syndrome. Most common area affected is rectosigmoid. Clinical features. So the disease presents within first 2 months of life. Fine. So first is failure of passage of meconium beyond 24 hours. So normal children, they pass it within 24 hours. And then there will be progressive abdominal distension. You see here, let's say you're going on the road in your car. Fine. You're going because your car has petrol. Fine. Let's say at this moment of time, your car petrol tank becomes empty. Now, you will be stuck up here. Same happens with the peristaltic wave. It will come up normally, but when there is no nervous system, the peristaltic wave will stop there only. Fine. Now, because of the stasis, many of the children may develop enterocolitis. And this is the common cause of death in children. Adults, they present with severe constipation. How can you establish a diagnosis? Anal manometry. So that will show absent rectoanal inhibitory reflux. Rectoanal inhibitory reflex. You know what is that? You see here. Rectoanal inhibitory reflex. Fine. So what happens is with this, If the neonates don't pass the meconium, then we may have, and the neonate starts developing abdominal distension, we may have to do manual evacuation. We may have to do manual evacuation of the fecal matter. Fine. Now, what is this rectoanal inhibitory reflex? Many of the time we all must have noticed that we are able to pass our flatus voluntarily, even though our rectum is full. Even though our rectum is full of fecal matter, but we are able to selectively pass. We are able to selectively pass the flatus, and we are able to withhold the fecal matter. Fine. That is because of coordinated contraction of the internal sphincter. Fine. So this is rectoanal inhibitory reflex. Fine. Now this is characteristically absent. This is characteristically absent. Fine. Now in the patients of Hirschsprung disease, also the gold standard investigation is the rectal biopsy. We may also say that it is the suction biopsy. So rectal biopsy done by suction method. Fine. That is the gold standard. That is the gold standard. We may also do conventional biopsy, but we prefer doing it by suction method. We prefer doing it by suction method. Fine. Now, the barium investigation, if we perform barium, fine. You see here, barium meal follow through, barium meal follow through. Fine. So it will give rise to saw tooth appearance, saw tooth appearance. Fine. Saw tooth appearance of the affected segment, Fine. So the surgical treatment option available are Swenson operation, Suave operation, and the Duhamel operation. Swenson, Suave, and the Duhamel operation. Swenson, Suave, and the Duhamel operation. Right? Swenson, Suave, and the Duhamel operation. So in the examination, they might want you to identify this. Fine. So this is Duhamel operation, where an extra loop is created. Fine. So this is end to side anastomosis. End to side anastomosis. End to side anastomosis. Swenson, Suave, and Duhamel. Fine. Now we move to the next thing there, intussusception. Intussusception. Fine. I want you to make note of this thing. So what is intussusception? Telescoping of one part of intestine into the other. Fine. Intussusception. Make no mistake, because there are common points of confusion there. Intussusception. So what is intussusception? That is telescoping of a part of intestine. Telescoping of a part of intestine into other. Telescoping of a part of intestine into other. Fine. Just a second. Just give me a second, please. Yeah. Now, you see, these are the parts of the intussusception. So the outer tube is called intussuscipiens. The inner tube, the entering tube, is called as intussusceptum, and the lead point, the entering point. Fine. This is called as the apex. Now, apex is considered most prone to ischemic injury. Most prone to ischemic injury. Now, you see this here. Fine. So it is common in children. And in children it will occur without an anatomical lead point. Fine. So most of the time it occurs because of mucosal edema and lymphoid hyperplasia. That means hypertrophied Pierce patch. Fine. So in children, a discrete, well-defined anatomical lead point is usually absent. Which kind of children? The infants. We are talking about the infants is usually absent, and it is due to hypertrophied Pierce patches, hypertrophied Pierce patches, hypertrophied Pierce patches, fine. Whereas in 90% of the adults, presenting with intussusception, a lead point is usually present. A lead point is usually present. Lead point is usually present. Fine. So it could be a benign tumor, it could be a polyp, it could be a benign tumor, it could be a polyp. Whereas in children, larger children, if a lead point is present, it is going to be most commonly Meckel's diverticulum, fine. So in children, if lead point is present, it is going to be Meckel's diverticulum, fine. Whereas in adults, it could be a tumor or a polyp. So let's sum it up. In the infant, it will occur without a well-defined lead point, fine. Whereas in children, it will commonly occur because of Meckel diverticulum, fine. It could also occur because of polyp, fine. Here, this will occur because of a villus adenoma, fine. What are the other, common lead point? A submucosal hematoma, for example, Hinoch scoline purpura. So these are the conditions which can give rise to intussusception, fine. Fine. Now, see what will happen here, because the intestine has entered the other part. So there will be emptiness. in the right iliac fossa, and there will be a mass in the right upper quadrant. That is called as sign of dance. Fine. So there will be a mass in the right upper quadrant. Remember, I told you that the apex will undergo ischemic changes. So there will be passage of blood mixed with mucus. That is called as red currant jelly stool. Fine. Now, here, the history will be characteristic. Mother will say that the child keeps on crying. She will say either the child cries or the child sleeps. Fine. So, child will draw his legs to the abdomen, Fine. Now, the different investigation, for example, ultrasound. Ultrasound will show donut sign, fine, will show pseudo kidney sign, fine. X-ray will show meniscus sign, fine. Barium anemia will show claw sign. Rotavirus diarrhea, yes, Dr. See here. See the donut sign, you can see it on your screens. And intussusception, fine. Meniscus sign, you can see on plain X-ray. Meniscus sign, plain X-ray, you can see. See here, the crescent sign, the crescent sign. Again, the crescent sign, crescent sign, right? See, the pseudo kidney sign, the pseudo kidney sign. Fine. Now, you see here the claw sign, the claw sign. Claw sign seen on the barium enema, seen on the barium enema. Claw sign which is seen on the barium enema. Fine. Now, so treatment is hydrostatic reduction wherever possible, wherever it is possible, so that controlled conditions are available. Air enema is preferred. Air enema is preferred rather than using saline or barium. Rather than using saline or barium, air enema is preferred. Air enema is preferred to cause the reduction. To cause the reduction, right? Now, if there is a third recurrence is an indication of surgery. And which method do we use? We use Cope's method of reduction. Cope's method of reduction of the intussusception. Cope's method, you can see on your screen, Cope's method. So Cope's method, what do? We just keep on milking it like this, fine. We don't pull the ileum out. We don't pull the ileum out. Fine. Rather, the ileum is pushed out from the colon. Ileum is pushed out from the colon. Fine. And if the surgeon feels that nothing is working, this part can be resected. This part can be resected. Fine. So that is your intussusception. That is your intussusception. Fine. Now, you see here, these are the, we start with the next topic there. We start with the next topic there. That is the lower GI bleed. Fine. Lower GI bleed, if it is fresh, it is called as hematochezia. Fresh, not mixed with the stools. Fine, not digested. That is called as hematochezia. Most common cause of hematochezia remains hemorrhoids. Fine. So that is the difference. That is the difference between upper GI bleed and lower GI bleed. Lower gastrointestinal bleed. Right. Now, the common causes of lower gastrointestinal bleed. If it is in the ascending colon, it is going to be angiodysplasia. Fine. If it is in the transverse colon, it's going to be ischemic colitis. Ischemic colitis. In the descending colon, it is going to be either infections. Remember the dysentery. Fine. Remember E. coli. Remember amoebiasis. Irritable bowel syndrome does not cause bleeding, Fine. Polyps. Fine. Carcinoma. Diverticular disease, the most common cause of bleeding in the descending colon. Bleeding originating from the descending colon. Fine. And in the rectoanal region, it is the hemorrhoids. Fine. Now you see hemorrhoids. So hemorrhoids, basically they are dilated veins with mucosal cushions. Fine. Now the pectinate line is the landmark. If the hemorrhoids are originating from above the pectinate line, fine, they are called as internal hemorrhoids. If they are originating from below, they will be called as external hemorrhoids. Fine. So if your patient is lying in front of you like this, fine, and let's say this is the anal canal. Draw a better diagram. This is too bad a diagram. Fine. So let's say this is the anal canal of your patient. You're standing between the legs of the patient. Fine. So the hemorrhoids, they will be present at typical location 3, 7 and 11 o'clock position, 3, 7 and 11 o'clock position. Fine. So they are either first degree, third degree or fourth degree, first degree, third degree or fourth degree. See here. Fine. First degree, there is no prolapse, but there is just bleeding. Fine. So clinical features, first degree, no prolapse, just bleeding. What is the treatment? Do sclerotherapy. Second degree, prolapse, but the prolapse reduces automatically. What is the treatment? Banding, or we say band ligation. Prolapse does not reduce. Fine. So it needs to be pushed back manually. It needs to be pushed back manually. Fine. Prolapse, and bleeding also occur. Prolapse. Fine. And it cannot be pushed back manually. So the only treatment option in both of them is surgery. Fine. So the surgery, if you can remember the name, Milligan-Morgan operation. Milligan-Morgan operation is open hemorrhoidectomy. Fine. Ferguson operation is closed hemorrhoidectomy. Fine. And Longo's operation is stapler hemorrhoidectomy. Fine. So the most common complication is pain. Fine. It can also cause urinary retention. Fine. See. Now, external hemorrhoids, simple thing. These are called as 5 days pile. They occur with chronic constipation and staining. They are extremely painful. See, internal hemorrhoids are not painful. Until they get thrombosed, they are not painful. Fine. Whereas the external hemorrhoids, they are excruciatingly painful. Fine. So they will resolve on their own after 5 days. If the patient is getting too much uncomfortable, you can give a small nick and get the blood clot removed. Fine. Now you see here. So this is how we do sclerotherapy. We will insert an irritating chemical here that will cause fibrosis, that will cause scarring, that will cause contraction. So the dilated venules, they will be retracted. This is band ligation done for second degree hemorrhoids. This is the hemorrhoid surgery done for third degree and fourth degree hemorrhoids. Fine. Now this is stapler hemorrhoidectomy. We call it Longo's operation. Fine. Longo's operation. Right. Now, why did this appear? See. Now here what was happening, that only the venules were protruding out. Only the venules and the veins were protruding out, and they were protruding out at 3, 7 and 11 o'clock position. Fine. Now what will happen in prolapse? If it is just mucosal, so it would be circumferential protrusion of mucosa. Circumferential, not just at 3, 7 or 11 o'clock position, but at all the position. 3, 7, 11 o'clock position are hemorrhoids, and if it is all around, let me just show you an image. See here. Fine. So this is prolapse, this is hemorrhoid, this is prolapse, and on the right side is hemorrhoids. Fine. You can see 3 things here. 1, 2, 3, 3, 7 and 11 o'clock position. Right. Now, whereas this is all circumferential. Now you can see here that here just the mucosa is protruding out, whereas here some of the muscles are also protruding out. Some of the muscles, they are also protruding out. Muscles, they are also protruding out. Let me just show you here. It's very simple thing. See here. You see on the right side, in the complete prolapse, the muscles are also protruding out. Muscles are also protruding out. Fine. So in the complete prolapse, the muscles, they also protrude out. Muscles, they also protrude out. Fine. Now, so there is a simple thing to remember. There's a simple thing to remember that in children we do Delome operation. Fine. And we can also do Thiersch wiring. So Thiersch wiring is preferred in children. Thiersch wiring is preferred in children. Fine. Alternatively in children, what can we do? Alternatively in children, we can just improve the nutrition. We can just improve the nutrition and the prolapse will go away. Now, we have two approaches aimed at treatment. One, we can do abdominal approaches. Second, we can do perineal approach. So here, speaking about the nutshell, what we do here is that the rectum is pulled back into abdomen, and it is fixed. Fine. Here, practically speaking, rectum is either pushed back or it is excised, Fine. Now the mnemonic here, which I keep on telling in the classes, is that who go to the war? If there is a war, who go to the war? Fine. So the young people will go to the war. Fine. So in young people, abdominal surgeries are done. What abdominal surgeries? Well operation. Fine. And Ripstein operation. Well operation and Ripstein operation is done. Well operation and Ripstein operation is done in young people. Fine. Well operation and Ripstein. See, rectum will be pulled back and then it will be fixed to the sacral wall like this. Ripstein operation. Fine. Rectum will be pulled back into the abdomen and it will be fixed to the sacral wall so that it cannot go out. This is the Thiersch wiring procedure which is done in children. Fine. That is also done in case of that is also done by the perineal route. Fine. So Delome operation and Altimede operation. So Delome and Altimede operation. They are perineal operations and they are preferred in elderly. Fine. Dr. Aniseri, yes, prolapse is common, especially in the children who have got very weak pelvic musculature, especially the children who have got very poor nutrition. So in those patients, the prolapse is extremely common. Fine. So simply we improve the nutrition and somehow we manage to get Kegel exercises done. There are multiple ways to get the Kegel exercises done from the children. For the children. So impotence can be a disastrous complication in abdominal operations. While we are handling the rectum. Fine. So that could be a severe complication. So what is there in the chronic anal fissure? There is a shaped ulcer, excruciatingly painful. Fine. There could be blood on the surface of the stools, blood on the surface of the stool. Jawahar ji, thank you buddy, thank you Mahesh ji. So what you need to remember is just the names, just the name. Fine, just the name. Just how will you differentiate? For example, they give you, just a second Jawahar ji, just a second, and see, if they give you this image, you should be clearly able to differentiate whether it is hemorrhoid or it is prolapse, so our understanding goes that they will give you typical images, if you get to see three things. Fine. If you go to three things, fine, you will know that these are hemorrhoids. Fine. If it is circumferential all around, naturally your inclination should be towards the diagnosis of prolapse. Fine. One thing is this. Second, if you don't want to remember too much, just remember this much, that for young people we prefer abdominal surgeries, for elderly people we prefer perineal surgeries. And remember the mnemonic: VOR, well, Ripstein, and A for abdominal. Thank you buddy. 3, 7, 11 o'clock. Yes. Now, so acute anal fissure, there will be cano-shaped ulcer, they will be very painful, while in the chronic anal fissure, there will be a sentinel tag, at the end. So let's say this is the ulcer, there would be a skin tag here at the end of the ulcer, that is called as sentinel tag. Fine. So what is the treatment? Either you can use calcium channel blocker creams. For example, you can use diltiazem. Fine. You can use nitroglycerin gel locally. Fine. You might want to give your patient stool softeners. Fine. What is the surgical treatment? Surgical treatment is lateral anal sphincterotomy. That will cause relaxation of the sphincter. Let me just show you an image. See, we are just going to cut the internal sphincter. We are not going to cut the external sphincter. Just the internal sphincter will be cut, so that the sphincter is relaxed. This is how we cut. We just want to cause relaxation of the sphincter, so that the blood coming in this area can cause healing. That is the surgical treatment. Fine. Now the next topic here would be the topic of fistula in ano usually starts from crypt abscess. Just understand it like this. Fine. You see here, let's say there is an abscess here. Fine. Now suppose this abscess keeps on getting bigger. Fine. Now because of the peculiar anatomy, let's say this is anal canal. Fine. Because of the peculiar anatomy, this will tend to open here. Fine. So what will happen? The pus will trickle down here. Fine. Ultimately, there are only two ways for a pus. Either you drain it surgically, or it will find its own way. Now, what will happen? The area around this pus will get epithelialized. Fine. And a well-defined tract will form. Fine. So this tract is called as the fistula in ano. Fine. Now fistula in ano. What do they ask in the examination? That is the Park classification. They ask the Park classification. See here. So type 1, that is the intersphincteric. So this is the internal sphincter, this is the external sphincter, and if you can see on your screens, this fistula is running between the internal sphincter and the external sphincter, internal and the external sphincter. Fine. Now one thing, this is the internal opening inside, this is the external opening. So internal opening and external opening of the fistulous tract you can see on your screen. Internal opening and external opening. One thing more which they ask here, now you see, this is the pelvic ring, right? This is the pelvic ring. That means the pelvic floor musculature, fine, pelvic floor musculatures. Now anything which is above the pelvic floor, if the internal opening is above the pelvic floor, this will be called as high type fistula. If the internal opening is below the pelvic floor, this will be called as low type fistula. Fine, low type fistula. Just a second. High type fistula or the low type fistula, that is the pelvic floor. Fine. The high type of fistula is usually rare, but it is still present. Fine. Now you see here, again they are going to ask you which is the most common pattern. So the most common will be intersphincteric. Fine. And you see this fistula is high type. Again, you should be able to differentiate between the intersphincteric, extrasphincteric, suprasphincteric. Suprasphincteric means which is opening above the sphincter, which is traveling above the sphincter. Fine. Extrasphincteric, that means which is traveling very far away from the sphincter. Again, they're not going to ask you this much detail. Only thing which they are going to ask is which is the most common type. So the most common type is intersphincteric. Fine. Let me draw this. What is this? They ask you about the Good-Sal's rule. So let's say this is your patient lying in front of you, and let's say you're standing between the legs of your patient. Fine. Let's say this is the anus. Of the patient. Fine. Now let's draw a line there. Let's draw a straight line there. Fine. Let's say this is the line. Now this is anterior, this is posterior. Fine. Now they say that if the external opening is lying in the anterior plane, the fistulous tract will be straight. Fine. They say if the external opening is lying in the posterior region, the fistulous tract will be curved, and internal opening will be in the midline. So this is your Good-Sal's rule. What do they ask? They ask about the exceptions. So you see, this is an inverted image. This is the posterior one. This is the anterior one. So you see here anterior, you can see straight tracks. Fine. Posterior, you can see curved tracks. Fine. What are the exceptions? So if there is a long fistula, in the anterior compartment and the external opening is at least 3 centimeters away, the fistulous tract in that case will still be curved, and internal opening will be midline. Also, the complex fistula, that means the branching fistula like this. Fine. So they usually open into the midline, Now you see, this is a complex fistula. First opening, second opening, third opening, multiple openings are there. So these fistulas, they don't follow the Goodsall rule. Fine. So treatment is either we can cut this fistulous tract, that is fistulectomy, or we can just open it up, that is fistulotomy. We can just open it up. Fine, we don't just remove the fistula, we just open it up. Or for the high fistula, we can use a seton. So seton is basically just like an absorbent thread. Now you see on the left side there is an abscess, and if we place a thread through this fistulous tract, fine, that will help to remove any pus, that is retained outside, that is retained on the inside of the fistula. Let me just do it. How do we do? So let's say you see some of the pus is retained. What will we do? We'll pass a thread from here. Fine. Then we'll bring it here. Then we will tie it. Now what will happen? All the pus which is present on the inside of the abscess, that will come out. This is how the seton helps. Fine, seton. This is how the seton helps. Now we move to the next thing, that is the valvulus. Fine. Now valvulus, it refers to twisting of an organ over its mesentery. Now this is most common in sigmoid. Why? Because sigmoid has long mesentery. The mesentery has a narrow base. The contents of sigmoid are solid. Content of the sigmoid are solid. Fine, let me just show you here. See, this is the base of mesentery, and I'm going to draw the mesentery here. You see, the mesentery is very long. The area which I have shaded green, mesentery, very long. Fine. Base of mesentery is very narrow. Contents are solid. This is common in elderly. So let's say around 60 to 70 years of age. Common in the patients who are having constipation. Commons in the patient who are taking neuropsychiatric medications. Why? Because the common side effect of these medications is constipation, which may cause loading of the colon, Most common direction of rotation is anti-clockwise. Fine. Plain X-ray may show these signs called as bent inner tube, called as coffee bean sign. Fine. This may also show coil spring sign. Before the valvulus is totally developed. Barium enema will show, you see, bent inner tube, coffee bean sign. Fine. So this is also called as omega sign. Fine. You see, this is what is seen on the barium enema, called as bird of prey sign, called as ace of spades sign, called as bird beak appearance, called as bird beak appearance. Now, if this is your patient, this is the right side of the body, this is the left side of the body. Fine. The coffee bean appearance, that is the dilated loop. You know, here what will happen, the convexity will be on the right side of the abdomen. Convexity will be on the right side of the abdomen. See, this is the right side of the abdomen. This is the left side. Fine. Convexity will be on the right side. Convexity will be on the right side. What is this? This is bird beak appearance on barium enema. Bird beak appearance on the barium enema. Bird beak appearance on the barium enema. Fine. So what we can do is we can pass a flatus tube, or we can do sigmoidoscopy, rigid sigmoidoscopy. If you do the rigid sigmoidoscopy, all the gases will come out and immediate detorsion will occur. Immediate detorsion will occur. After that, we can perform elective sigmoidectomy. Once our patient has stabilized, then we can remove the sigmoid, because it has chances to undergo repeat valvulus. Fine. Now, this valvulus like thing can occur in the region of cecum also. Fine. Now, you see here, this is small intestine, this is cecum. Fine. So one type of rotation can occur along this axis, Fine. So that is called as cecal valvulus. So basically, it is not cecal valvulus, it is colic valvulus, because all of the other organs are also involved. Now, this can also occur along this axis. Twisting can occur along this axis. You see here. This is called as cecal bascule. Yes. So what did I tell you? It is anti-clockwise only, Jawaharji. It is anti-clockwise. Sigmoid valvulus, did I mention clockwise? No, but I mentioned anti-clockwise only. Sigmoid valvulus. Sigmoidoscopy, Dr. Level Up. First we'll do sigmoidoscopy. See, flatus tube you will be able to pass only after you do sigmoidoscopy. Rigid sigmoidoscopy. Fine, rigid sigmoidoscopy. So you have to understand the difference between cecal bascule and cecal valvulus. Fine. Sigmoid valvulus, there will be large bowel distension. Fine. Whereas in the cecal valvulus, there will be small bowel dilatation. How are you able to differentiate between the small bowel distension? Fine. So you see, large bowel distension will more be on the sides of the abdomen. Fine. Small bowel distension will more be centered on the inside. Large bowel on the outside, small bowel on the inside. Apart from that, fine, you will have a dilated loop, and the convexity of the loop will be towards the left side. Fine. And you see here, it is towards the left side. Fine. So this is called as embryo sign. Fine. Embryo sign. Right. Now, Cecal valvulus is more common in patients who are 50 to 60 years of age. The direction of rotation is clockwise. Direction of rotation is clockwise. Fine, clockwise. Now, embryo sign is seen. Embryo sign is seen. Right? Now, very quickly, because we have some time, I wanted to keep the class short, but let's quickly see if we can study this big topic. If we can study this big topic. Fine. That is vermiform appendix. So first they ask you in the anatomy. The age of valvulus, Dr. Lovely, is 50 to 60 years for cecal valvulus, 60 to 70 years for sigmoid valvulus. Fine. Now you see, they ask you a question in anatomy, which of the three structures they are lacking in appendix. So appendix does not have appendices epiploicae, the fat pads. Appendix does not have haustra and speculation. Appendix does not have tinea coli. So these three structures they are lacking in appendix. Fine. In fact, the base of the appendix lies where the anterior tinea coli ends. That is where the base of the lie. Now, when we say position of the appendix, we are talking about the tip of the appendix. So most commonly it is going to be retrocecal. Second most common it is going to be pelvic. Pre-ileal and post-ileal, these two positions are called splenic because you see they are pointing towards the spleen. Fine. Post-ileal is the least common, the rarest of the position. Least common is going to be the post-ileal. Fine. And I told you most common it is the retrocecal. These are the kind of question which they ask. Fine. So appendicitis, most common age is 10 to 30 years. That means it is the disease of young. It is slightly more common in males. So commonly it is associated with a fecolith. If it is not associated with fecolith, it is called as catarrhal type. So catarrhal type is more common in children. Let me just show you a fecolith. See, a fecolith might obstruct the path of lumen, and here the infection will flourish like anything. Fine, will flourish like anything. Just a second. Now you see here, first of all the pain will appear near the umbilicus. Clinical features, so we call them Murphy's triad. Don't confuse it with Murphy's inspiratory arrest sign, which is seen in acute cholecystitis. So there will be pain will be first felt around the umbilicus, then it will move to right iliac fossa. We call it migratory pain. Fine. So your patient will also have nausea, vomiting, and this vomiting is usually just single episode, and that is enough for us to differentiate it from acute gastroenteritis fever that is rarely 1 degree centigrade above normal. Fine. Now see, Murphy's triad. Fine. Pain, first it will appear here, then it will migrate to the right iliac fossa. That is called as migratory pain. There will be hyperesthesia in the Sharon's triangle, umbilicus, pubic tubercle, anterior superior iliac spine. There will be hyperesthesia in this triangle. Patient will point out that where he is having the pain, where at the McBurney's point. McBurney's point. What is McBurney's point? Fine. So if this is anterior superior iliac spine, this is umbilicus. 2/3 of the distance away from the umbilicus and 1/3 away from the anterior superior iliac spine is the McBurney's point, where the patient will be pointing his finger. Fine, that is called as the pointing sign, Rovsing sign. So let's say the colon is like this, and at the end of the colon is lying the umbilicus. Fine, you see, if you're pressing over here, so if you press in the left iliac fossa, there will be pain in the right iliac fossa. That is called as Rovsing sign. Rovsing sign. Where else do you get to see Rovsing sign? Rovsing operation you do in case of multiple cyst, polycystic kidney disease. Rovsing sign, another Rovsing sign you see if there is horseshoe kidney. Fine. Rovsing, the word comes quite often. I'm glad, buddy. I'm glad. Fine. Bloomberg sign, when there is rebound tenderness. When there is rebound tenderness. Not just tenderness, but rebound tenderness. Fine. Rebound. For example, you keep on pressing and then you suddenly release. There will be pain. That is rebound tenderness. Rebound tenderness. Fine. Rebound tenderness. Psoas sign. Retrocecal appendicitis. There is hyper extension of the right lower limb. This is what happens in psoas sign. Fine. Obturator sign. Obturator sign, that is medial rotation of the lower limb. Now, there are other signs, that is Dunphy sign. Pain on cuffing. Pain on cuffing. Tenhorn sign. Pain on gentle traction on the testis. Pain on gentle traction on the testis. Fine. Now, what is the treatment? Standard treatment is you should perform appendicectomy. You should perform appendicectomy as early as possible. That is within 72 hours. Within 72 hours. Fine. Now, the treatment. Open surgery or laparoscopic surgery. But if they ask you what is the surgical treatment of choice, surgical treatment of choice is laparoscopic appendicectomy. Fine. If you do it by open approach, you are going to give McBurney's incision, also known as MacArthur incision, also known as gridiron incision, which is just a muscle splitting incision. If you cut the muscle, it becomes Rutherford incision. Name of the incision is important. Fine. Lance incision, also called as Bickeney's incision, is considered more cosmetic incision, and it is preferred if it is preferred for women. Fine. If Oshner-Sharon's approach, if you are not able to operate it within 72 hours, fine, and an appendicular lump form, so that is a non-operative approach. You give IV antibiotics, IV fluids, you keep the patient NPO, you keep on measuring the vital parameters of the patients. Fine. Oshner-Sharon's regime or Oshner-Sharon's approach, that is non-operative treatment of appendicitis. This should be followed by interval appendicectomy. Can any one of you please answer? What is the type of wound which will form in acute appendicitis if you do surgery in acute appendicitis? Will that be different from the type of wound which forms after you do interval appendicectomy? Any one of please? Dr. Any, I'm trying to ask you a question on this. That is the kind of question I'm asking here. Yes, exactly, Jawaharji. They will ask you they will ask you the different signs. They will ask you the Murphy's triad. They will ask you the migratory pain. Fine. They will ask you the name of the incision. They will ask you what is preferred surgery. What kind of surgical wound will form if we are doing interval appendicectomy? At what kind of surgical wound will form if we are doing appendicectomy after acute appendicitis? So interval appendicitis will give rise to clean contaminated wound. Fine. Whereas if you do surgery after acute appendicitis, it will give rise to contaminated wound. That is type 2 and this is type 3. This is type 3. If you do surgery on a patient who develops appendicular abscess, it will be a type 4 wound, that is dirty infected wound. Now what is this? Mentorals, that is the mnemonic of Alvarado score. Alvarado score. What do you see here? We see if your patient has migratory pain, anorexia. It was considered most specific sign some times ago. Fine. Nausea or vomiting. Tenderness in the right iliac fossa. Remember, it has double importance. Fine. Rebound tenderness. Fever. Fine. Fever, that is, this pain, nausea. Fine. Fever, Murphy's triad. Leukocytosis, increased total leukocyte count. That also has got double importance. Shift to the left, that means many more new neutrophils, fresh infection. Fine. Now, if the score is 5 to 6, that is the indication of contrast CT, which is the investigation of choice in adults. In children, the investigation of choice still remains ultrasound. After doing surgery, you look for the presence of carcinoid tumors, and if the carcinoid tumor is more than 2 centimeters in size, we know that this tumor must have gone to other places. So what do? Right hemicolectomy. Apart from appendicectomy, we will do right hemicolectomy. If it is less than 1 centimeter, we know that this tumor must not have gone anywhere. So appendicectomy only is the sufficient treatment. No need to do anything else. If the tumor is more than 1 centimeter but less than 2 centimeter and the tumor is located at the tip, we know that there are very less chances that this tumor must have gone anywhere else. We say appendicectomy is the sufficient treatment. If it is at the base, we know that this tumor could have gone to other places. So we still perform hemicolectomy, right hemicolectomy. Lily white appendix is the non-inflamed appendix. Fine. Now, see here. Meckel's diverticulum. So it is present on the anti-mesenteric border of intestine. Fine. Now it is a true diverticulum because, as you can see in the image, it has all the layers. Why does it have ulcers? Because it may have pancreatic epithelium. Fine. It may have pancreatic endothelium. It may have gastric mucosa also. It may have gastric mucosa. Now both of them, they can cause ulceration. Fine. Now what is the rule of 2? Half of the symptomatic patients are less than 2 years of age. Fine. So you see in the Meckel's diverticulum, half of the symptomatic patients are less than 2 years of age. It is present in 2% of the population. Fine. Two type of mucosa, that is gastric and pancreatic tissue, can be present. It is present 2 feet away from the ileocecal junction. It could be 2 inches long. It could be 2 inches long. Fine. So I wanted to keep this lecture, today's lecture, very short. So I did manage to keep it short. Fine. Now rest of the topic will be studying in the form of questions. We'll be studying in the form of questions. Fine. So if you have got any queries, do let me know. If you got any queries, do let me know. Looking at the live chat feed. Treatment of cecal valvulus, because here the derotation usually is not possible, so we have to excise it. Dr. Level Up, we usually have to excise it because the derotation is not possible usually. If we are able to obtain derotation, we will perform fixation. So that is called as cecopexy. Dr. Johar, I still can't believe, because I sent 3 PPTs. In fact, 4. I did send 4 PPTs, and they had all the important images. So I'll make sure the PPTs they reach you. In the last lecture also I told you that I did make 3 PPTs. I'll try some way out that the PPTs can reach you. I'll try some way out. Hashimji, internal hemorrhoids are painless. Very good question. So let's say this is the pectinate line. Fine. On this side, this is mucosa. This side, this is skin. So this is full of nerves. That is why the external hemorrhoids are extremely painful. Mucosa. Fine. So this mucosa is only sensitive to pressure. This we can easily call as insensate. Even if you cut this mucosa, there will be no pain. Dr. Level Up, that depends upon the experience of the surgeon. If the surgeon is experienced, he can do it laparoscopically. So in the examination, the choice option will include cecopexy. Go in for cecopexy if it is there in the option. Cecopexy means fixation of the cecum to the posterior sacral wall. Laparotomy. I mean, if I would do it, I'll do it by laparotomy. But if an experienced surgeon will do, he will do it by laparoscopically. You can do it laparoscopically. These days, you know, the surgeon, they are doing Whipple's operation laparoscopically. All the bigger surgery, they are doing it laparoscopically. Chalo, I'll end today's class if you don't have any more queries. And I'll make sure, I'll try my level best that all the PPTs they reach you. All the PPTs they reach you. Who's there? So level up, bro. Just a second. Oh, we are yet to open that PPT. Just a second. You did forget to see that just a minute, no problem. I'll explain. Dr. Level Up, you see here, this is mucosa and this is skin, and there is a cut in the skin, cano-shaped ulcer. Cano-shaped ulcer is there in the skin. Right? We'll study rest of the topics in the form of questions. In the coming lecture. In the upcoming lectures, we'll have more of questions there. Right? Thank you. Thanks for your time. Always glad to be with you all. Right? Thank you so much.